All right, so welcome everybody. The first of our series, part one, is titled Epidemiology, Overview and Introduction to Indigenous Health and Wellbeing Research. My name is Saida Mäki-Penttilä, and I work at the Finnish Institute for Health and Welfare, the Cultural Diversity team. My apologies for my voice. I'm a little under the weather, so my voice is a bit bunged up. If you have a moment, we would love for you to answer the survey. You can hold your camera of your phone on the QR code, and there's a couple of questions just so that we can get an idea of who is listening to us today. And it's a really great joy to have this first part of our webinar series that we've been planning for a while with our colleagues at the Sámi Parliament, the Center for Indigenous Health, and the University of North Dakota. And we're so excited to progress with today's webinar. Rita, would you like to say a couple of words? You need to open your microphone.
Okay, I have my microphone on. Okay, thank you, Saida and Pohkaite. Hello, everyone. And I'm Riitta Lehtola-Kosonen, and I work as a secretary as a social affairs and health at Sámi Parliament. And we are very excited about this collaboration and the webinar series. And this is a new collaboration in Indigenous-based social and health research, and we hope that the participants will gain new ideas and approaches from this webinar series. So I'll thank you already, Dr. Andrew Williams, and all of who participated in this event. Thank you.
And just a couple of housekeeping. We have the Q&A box, which can be found on the top of the header of the Teams meeting, where you can ask questions as we move along, and we will take them at the end of the presentations. But without further ado, Dr. Andrew Williams, would you like to start?
Absolutely. Thank you so much for having us. We're really excited about this webinar series and looking forward to the conversations today and over the next few weeks as well. Today, we will be doing a brief epidemiology overview and an introduction to some of the pieces of Indigenous health and well-being research. We will be first talking a bit about population level health surveillance and some of the approaches that we currently take, mostly from a US-based angle, but also talking about how it does or does not work for Indigenous populations. And then we'll do an overview of some Sámi research as well. I'm an assistant professor in the Department of Population Health. I also am executive director of the North Dakota Perinatal Quality Collaborative, so a little bit of epidemiology, a little bit of applied work in what I do. But I also teach epidemiology in the Indigenous Health PhD program that we have at the University of North Dakota. And one of our students will also be presenting a bit of her work from one of her courses. Anna Kielström is from Helsinki and is an Indigenous Health PhD student at the University of North Dakota with a background in nursing and a master's degree in public health. She currently works as an Indigenous health and public health consultant with interests in decolonizing and indigenizing research practices and exploring intergenerational trauma and resilience among Indigenous populations. And before I get into my portion of the talk, I'll turn it over to Dr. Donald Warren, who will be leading the next few sessions after today.
Hello, my name is Dr. Donald Warren. I'm Oglala Lakota, originally from Kyle, South Dakota on the Pine Ridge Indian Reservation. So I'm Indigenous. I'm also a physician and have training in public health, health policy, and social research. I've been very honored to serve as the co-director of the Center for Indigenous Health at Johns Hopkins University, one of our partner organizations in the webinar series. And prior to that, I was the chair of the Department of Indigenous Health at University of North Dakota, where we developed the curriculum in Indigenous health. And I'm just so pleased to see the outcomes of that. In our first 5 cohorts of students, we were able to matriculate 70 students into the PhD in Indigenous health. And you'll hear a little bit from one of those students, Anna Kielström, a little bit later. So we've been working collaboratively with the groups listed here and recognizing the need for a webinar series focused on Indigenous health and well-being. So we can go to that next slide. In terms of an overview, this is a 3-part webinar series, and it's focused on Indigenous health and well-being research. And wonderful to work with THL, the Sámi Parliament, of course, Johns Hopkins, and University of North Dakota. So in terms of the series, we're really looking at engaging researchers and students to deepen the understanding of Indigenous research methods. As Indigenous peoples, we've been conducting research, doing program evaluation and public health work for thousands of years. We just have different methodologies and different ways that we measure quality and outcomes. So we'll be talking about that in the webinar series. We also want to look at health and welfare professionals who are working with the Sámi population and other Indigenous peoples, as well as policymakers and organizations developing culturally sensitive services and research projects with diverse populations. And it's wonderful to be inclusive of Indigenous peoples. So very briefly, our webinar today will be led by Dr. Andrew Williams, who you just met, and he'll be covering the epidemiology overview and introduction to Indigenous health and well-being research. And then I will lead the next 2 webinars. On May 20th, we will be looking at Indigenous determinants of health, which is a project we've done through the United Nations Permanent Forum on Indigenous issues. And then also strengths-based measures, not just looking at disparities, but what are the strengths in Indigenous cultures that are protective of health. And then our 3rd webinar will be community engagement and data sovereignty. So very much looking forward to engaging all of you in this wonderful and important webinar series. And I'll go ahead and hand it back over to Andrew. And I think you've already had our biographies, so we can go into Andrew's presentation, but thank you very much.
Absolutely. Thank you. Thank you, Dr. Warren. So today for this session, we'll be talking about why we monitor population level health status, and think about some of the standard approaches to collecting data. We'll also be thinking about approaches to improve research and data collection among Indigenous populations. Anna will also be talking a bit about how some of these approaches and critiques of the Western approach to data collection in essentially a case study of the FinHealth study, so looking at data very specific to Finland and the Sámi population. And then I'll touch a bit on where we're at with Sámi epidemiologic research. Just as a disclaimer right now, I don't expect my conversation to be a full coverage of research, but at least looking at where we're at now in comparison to some of the data collection issues that we'll be talking about in the session today. When we're thinking about monitoring population health status, this is the systematic collection, analysis, and interpretation of health data across entire populations. And when we say entire populations, we do typically think of collecting everybody in a country, in a geography at the same time. But what we've learned over the decades of really taking this approach is that in order to best understand entire populations, we may need to take different considerations into account for different segments of the population, whether it's different racial populations, geographic populations, socioeconomic populations. Taking one standard approach oftentimes doesn't give us that true picture of the entire population. But the core functions of collecting population level data is really tracking the health status indicators. Mortality, morbidity, disability, different types of exposures can be tracked. We also want to make sure that we're identifying emerging health threats and disparities. And this can range from everything from infectious disease outbreaks to looking at the increase in type 2 diabetes in children in the United States over the last several decades. So both chronic disease and those more acute diseases all fall within this scope. And then we can also measure the impact of health policies and interventions. So if there is a broad health policy change, such as how healthcare is paid for, we may be able to see different types of health status changes over time. And we really want to make sure that we're not just focused on individual patients, but really be thinking about the collective health outcomes. So what are rates among populations? How is the population doing? Which can then help us inform other pieces of public health. So the reason that we do population health monitoring, largely the first piece is evidence-based decision making. We want to make sure that when we're allocating healthcare resources, we can target those populations that need and target certain resources to populations that may need more cancer-related, for instance, cancer-related resources compared to, young family-related resources. We can also set public health priorities and goals based on the burden of disease. In the United States, we have what's now called Healthy People 2030, that essentially sets national priorities for everything from chronic disease to infectious disease to pregnancy health, child development, all informed by the work that's done in surveillance systems. And then we can also, again, target interventions to those high-need populations. Monitoring population health also helps inform things like early warning systems. So like I had said, potential disease outbreaks and emerging health threats. We can also identify unexpected changes in our health patterns, and obviously this can differ based on which type of health outcome or disease that you're looking at. And then when we have data and we understand where some of these early warning signs are, it can help enable rapid public health response. And this works in a variety of contexts. Obviously, in places like the United States and in Finland, most recently, we obviously had a COVID-19 pandemic. In the US, we're currently dealing with a measles outbreak, but also works in other contexts like in Africa, where they've had recent outbreaks of some hard to identify diseases recently, but able to respond to those rapidly, help contain some of those threats. And then population health monitoring also helps us link to health equity. It can help us uncover disparities across a variety of different geographic, socioeconomic, and demographic groups. It can also help us address social determinants of health. And then we can also measure progress toward reducing health inequities. And so this is really going to tie into some pieces of how are we collecting data and what types of data are we collecting, so that way we can have an understanding of who are these different populations that we need to maybe pay special attention to with our efforts. And when we have the data and we have the systems in place to utilize the data, we can then take different public health approaches in different arenas to help improve population health. And we oftentimes first think of policy development. This is where we'd be using our data systems and our efforts to inform evidence-based health policies and regulations. We can evaluate the effectiveness of existing programs for a variety of populations. And then we can also use the policy development process and the data collection process to help justify investments for certain types of preventive health measures. So we're not just addressing illness and sickness after it occurs, but writing policies and implementing programs that will actually keep people healthy, as opposed to responding after they're already sick. It will also help with strategic planning for public health goals. As I said, in the United States, we have systems like Healthy People 2030. Each one of our individual states and other jurisdictions put out regular public health plans as well. Organizations like the American Heart Association, March of Dimes, which focuses on perinatal populations. All of these organizations use existing public health data to help inform strategic plans for what they want to do in the future, how they're going to fund things like research and programs. It also helps identify those trends to anticipate future health needs. So not just responding with an acute crisis, but also looking at how, for instance, a population ages and how we need to maybe shift some of our goals in terms of caring for a larger proportion of elderly patients in the future. And then also benchmarking against similar populations and looking at best practices is possible through this type of surveillance as well. And what's especially important when we're thinking about Indigenous health, and we'll get into it a bit later, is community engagement. We want to make sure that we're communicating health risks to the public. We also want to make sure that communities are empowered with knowledge, data, and those tools to take action to help improve their own health status. Because we can do a lot at the federal level, we can do a lot at a regional level, but so much of health happens in community, in families, in households. So having that knowledge out in those communities is really important. And perhaps most importantly, through community engagement, we can build those partnerships for collaborative health improvement initiatives to make sure that governments, organizations with resources can maybe bring those resources to community and have community really inform some of those approaches and take ownership over those roles. Next, I want to review just a few of the kind of standard monitoring systems that we have in the United States. A lot of our monitoring systems happen at the federal level. The Centers for Disease Control and Prevention oftentimes do a lot of collaborative type agreements with states in the US. So data collection may happen in joint with the CDC in the states, and there's some shared data ownership over those types of systems. And some examples of organizations and surveys that the CDC takes over or takes control of is the National Center for Health Statistics. They run National Vital Statistics programs. They run the National Health and Nutrition Examination Survey, which I'll talk a little bit about here in just a few seconds. National Health Interview Survey. So some of the really big, commonly known, commonly used systems that give us that picture of health over the whole population in the United States. And then we also have some more kind of condition-specific, disease-specific systems as well. Given I'm a perinatal epidemiologist, I do use PRAMS data a lot, which is the Pregnancy Risk Assessment Monitoring System. And that's a partnership from the CDC with the majority of the states in the United States on surveying people who recently had a baby. So just to review some of the common surveillance systems that we have. And as I said, we kind of look across a range of different types of health conditions and health factors. The behavioral risk factor surveillance system is one of the largest surveys. I do believe it's one of the largest health-related surveys in the world. They collect data from several 100,000 people every year, and it is a telephone-based survey. And so we look at pieces such as physical activity, diet, smoking, alcohol use, etc. So really looking at some of those behavioral risk factors. And this was originally designed targeted more towards adults, but there is also a youth version of this surveillance system. Both of these surveillance systems are in partnership between the CDC and states. States do have quite a bit of control over the types of questions that they ask and how that data is managed. And then the National Health and Nutrition Examination Survey combines some survey questions with some biomedical sampling. So how NHANES, as we typically call it here in the US, works is they have mobile clinics that they call them mobile exam centers or MECs, and they go and they sample like 15 counties, so smaller jurisdictions within states, 15 counties around the country every year. And then these mobile exam centers drive out to these communities, whether they're rural or urban or suburban, and people come to the clinics. They get things like some blood draws done, blood pressure, height, weight, take some nutrition surveys, take some health behavioral surveys, etc. So with the NHANES data, we're able to link some social factors. They don't have great social data in that survey, but some factors with the biomedical specimen. And one of the strengths of NHANES data is we're able to use things like the blood samples to look at concentration of environmental contaminants within the body. So there's the power of doing that at the population level that we have. And then the Pregnancy Risk Assessment Monitoring System, as I said, it's a collaboration between the CDC and most of the states in the United States. Not every single state participates right now, but it's a survey-based program done over the telephone, asking questions of women that have recently given birth. They ask about their experiences during pregnancy and the 12 months preceding pregnancy. So there's some health-related questions such as smoking, drug use, alcohol use, access to care, utilization of care. But then they also ask a lot of social questions like adverse childhood experiences, intimate partner violence, access to resources, information sharing, etc. And so this is able to collect data from new moms. And it's really valuable because they do it so soon after the birth that the data is actually really quite accurate. And it's done at the population level. And one of the nice things about PRAMs is that the states have so much control over their sampling method that in states like North Dakota and states that have a large American Indian population, they'll oversample that population so we can actually have estimates specific to Indigenous populations in our states. And then the National Center for Health Statistics also has a vital statistics database. And this is a fairly powerful tool that we can link to some of these other surveys I've mentioned here, especially NHANES and BRFSS. So there's birth records, death records, linked birth death records within that vital statistics database. And I've already mentioned some of the data collection methods, so I won't go over through these in detail. But a lot of them are telephone surveys, in-person interviews or questionnaires, as I said, some lab-based biologic specimen, health records, and then administrative health data. So kind of the standards that you probably already are thinking about when you're thinking about population health surveillance and how that works. But with some of these methods, we do have some obvious limitations for Indigenous populations here in the United States. So I'll touch on a few of them. Anna will talk a little bit more about some of these with her case study as well, and we'll talk about addressing them later as well. But oftentimes in the United States, we do have issues with a limited representation of Indigenous populations in our data. And that is there's a variety of reasons that can happen because of the geographic location of many of our American Indian populations are in reservation areas or very rural areas. Sometimes they're very hard to reach physically, especially with something where we have to go out into the field and collect data. But we also have a very high percentage of the American Indian and Alaska Native population in the US that resides in urban locations. But a lot of the Indian Health Service and American Indian Serving services don't always map over well into some of those rural areas. So they can be this population that can kind of fall through the cracks if we're just going to do this very standard approach. We also oftentimes just aggregate all American Indian and Alaska Native people into one group. The issue with that is that we have, I always get the exact number wrong, 574 federally recognized tribes in the United States. We have other tribal nations that are only recognized by the states that they reside in. And then we have other tribal communities that have no recognition whatsoever that are working towards that. So we have a lot of different populations that are oftentimes collapsed into this one group. And so we know there's differences, especially if you're looking across broad geographic regions like the entire country. And then the last point is important for some of our youth-based surveys and our school-based surveys. The Bureau of Indian Education runs a number of schools specific for tribal populations in the United States, and they've been excluded through policy for things like youth behavior risk surveillance surveys and those types of approaches as well. So just through simple policy reasons, we're missing some of those key populations. And then one of the largest kind of persistent issues across a lot of our surveillance systems in the United States is racial misclassification. Some estimates estimate that up to 30% of American Indian and Alaska Native populations are identified as some other racial group. And so that is an issue with how we're classifying data. For example, when it comes to death certificates and vital statistics, oftentimes in the US, when we're filling out the racial classification on a death certificate, the person responsible, whether it's a coroner or a physician or another health professional, simply looks at the person and fills out the form based on what they feel that person looks like. And oftentimes, as we see, that can be wrong because there's a lot of variety in Indigenous populations, and we can't just base those decisions on what someone looks like. We also have a high number of multiracial Indigenous individuals. And oftentimes they're categorized separately. They may be put into a 2 or more races or multiracial group in things like our census data. How we've coded race in the past is if we're looking at Hispanic and Latino populations who are also Indigenous, oftentimes they first get grouped as Hispanic and then they're left out of the Indigenous populations. And then the last point would help with some of the disaggregation issues that need to happen. We know that tribal affiliation is rarely collected. And so we may have, within the state of North Dakota, we have 4 tribal nations headquartered in North Dakota. A portion of a 5th tribal nation also exists in North Dakota as well. And so we have a variety of tribal nations that exist, but we have sometimes difficulty identifying individuals and populations for each one of those tribes. Now, many of these issues that I just identified could be addressed through changes in some data collection measures, because with the challenges that we have leads to a lot of questions in our data and missing pieces in the data. So first of all, if we're going to be doing a lot of phone-based surveys in very remote rural areas, which a lot of our reservations are, we don't have great telephone service. Some places may not have any telephone service or other types of utilities. And so they're just simply not showing up in some of those databases we're using to try to collect those that data from those populations. There can also be some language barriers if surveys are only in English and Spanish, as Indigenous languages are commonly used in many of our tribal populations, and that may be the first language for a lot of the populations that are trying to be surveyed. There's a lack of cultural understanding in some of the question design. So it may be insensitive in terms of how you're asking the question about family relationships and health status and health behaviors. For instance, we always collect data about smoking and tobacco use in our health surveys, but traditional tobacco use is a part of many Indigenous cultures in the United States. And so delineating between traditional ceremonial practice with tobacco versus commercial tobacco is something that it needs to be done, and thankfully it's moving slowly in that direction to try to delineate those 2 types of tobacco use. And then, as I've mentioned, there's some geographic isolation limiting participation in some of these data collection efforts. And also with some of the methodological barriers stem from limited tribal control and limited tribal participation in the United States. So many of these surveillance systems may operate without any type of tribal consultation whatsoever. Even though the federal government has treaty obligations that involve health and healthcare with the tribes in the United States, this important piece of public health and informing future health is not taking all of that into account and partnering with tribes. Tribes often lack access to their own health data, so even if they are part of some of the data collection efforts, they may not be able to store the data, may not even be allowed to store the data themselves. And so they don't have access to that data. A lot of the surveillance system data that I just talked about remains with federal and state agencies. This is often there's a tiered approach to collecting data between local, state, and federal organizations. Some states are taking steps to share data with tribal populations and tribal surveying organizations better than others, but the ownership is really where we'd like to get to with some of these future steps. And then there's few formal data sharing agreements with tribes, and there's difficulties getting access to some of that data as well for reasons both good, like getting data use agreements set up with each tribe and having tribal approval for using the data, and then bad reasons where it's just states may not want to share data with tribes because they're not part of the state infrastructure. So a lot of kind of legal and policy issues that still need to be worked out with that type of approach. Now, getting to some of a little bit of what Dr. Warren will talk about over the next few weeks. Thinking through Indigenous health frameworks both relates to what we can look at in terms of collecting data for Indigenous populations, but then also frameworks for how we can, store data, manage data, etc. And the image I have up is the medicine wheel that takes the approach of thinking through health and well-being from a physical, emotional, mental, and spiritual. The medicine wheel, if you haven't seen it before, is commonly used in many indigenous populations in the United States, especially in the Northern Plains area, like North Dakota is. So just be thinking through that there are different ways of thinking through health and well-being that we can also use to inform our approaches. So in general, one way of viewing this is to take a holistic view of health when thinking through what Indigenous health looks like. There's a connection to land, culture, language, and community as health determinants. There's also a lot of historical context that we need to take into account with intergenerational aspects of colonization and thinking through not just what has happened over the past several hundred years, but things that are still currently happening related to colonization and those policies. And really want to be thinking about, it's not just an absence of disease that leads to health and well-being, but also a balance between these different pieces of the medicine wheel, and thinking through harmony and what that means for health and well-being, as opposed to, well, you have cancer or you don't, you have diabetes or you don't. It's a more holistic approach to that. And then there's a few data frameworks. I'm not going to go into these in detail. These are resources I could share links out to and papers out to. But there are approaches to thinking through Indigenous data frameworks. From Canada, there's an organization that's developed what's called the First Nations OCAP, so thinking through ownership, control, access, and possession of that type of data. And then things such as the CARE principles, collective benefit, authority to control, responsibility, and ethics. So thinking from the tribal side, the Indigenous nation side of who has ownership and control and possession of these data, and what are the ethical implications for that. Now, Dr. Warren's going to get into much more detail on some of these issues, but just wanted to highlight what we're talking about when we think through some Western approaches versus some Indigenous health indicators. So when we're thinking through some standard indicators, these are things like body mass index, blood pressure readings. Are you getting screened for certain health outcomes? Or do you smoke? Do you use other type of substances? So it's really thinking through things like medical and clinical relevance of these measures. And as you can see, these are very health behavior, physical health, biologic health type of indicators that show up, whether it's directly measuring these in blood draws and medical samples, or survey questions related to some of these approaches. But what's often missing, especially when we're talking about Indigenous populations, is thinking through things like traditional food access that is very important for their health, cultural knowledge transfer between individuals, between generations, how an individual interacts and participates in community. So things like ceremony, cultural knowledge, use of language and language fluency. And Dr. Warren will specifically address this last piece in the coming weeks, but thinking through deficit focus versus strength-based approaches. And so what we think here is not just thinking about, in the United States, there is a stereotype that all Indigenous populations are very sick, all Indigenous populations have poor health. But we know that there are a lot of strengths and opportunities within all of those populations as well that should be measured and should be considered when thinking through data collection. So when we say deficit focused, some of those things are still important to collect, such as cancer screening rates and substance use and mental health conditions, but also be thinking through strength-based approaches like traditional food, some of the cultural pieces, the ceremonial pieces that have been practiced for many, many years by Indigenous populations and are a key part of their health and well-being. And now thinking just through some promising approaches in the United States, I'm going to cover some of these in a little bit more detail as well. But when we're thinking about data collection for Indigenous populations, we have 12 centers, tribal epidemiology centers that are tasked with serving tribal communities. So we could use some of these techs, as they're called, to a greater degree, because they're spread out across the country and they're organized by region. So they're knowledgeable about their regional needs, and there is that sort of pre-existing network for potentially improving our data collection. There's also some tribally driven surveillance systems that have led to more accurate and relevant data. In South Dakota, they did a tribal version of the PRAM, so that's the pregnancy surveillance system, and they achieved a 73% response rate through community partnerships. Typically with PRAMS surveys, we're lucky if 50% of the survey participants respond. So a much better job when focused on the tribal aspect. And then the White Mountain Apache tribe in the southwestern portion of the United States, they have a suicide surveillance system, and that was mandated by tribal resolution. So it was really a tribally driven approach to that. We also want to make sure we have some formal data sharing agreements that respect tribal sovereignty, and more community-based participatory research approaches, so letting community drive what's happening with the data collection. And then one key thing that happens is the oversampling Indigenous populations in national surveys to improve data. As I said, for things, especially like PRAMs, states do oftentimes oversample, but it doesn't necessarily happen in all of our systems at the national level. So moving on to some more specifics about how we can improve public health data systems for Indigenous populations. Just as a note, a lot of these next few slides have been informed by the work that I do with PhD students in our applied epidemiology course. One of their assignments, which Anna will do a brief overview of hers in a few minutes, is looking at existing public health data systems and then critiquing them from an Indigenous lens. So didn't have the space to list every single person, so you'll see some pictures populated of our students just as a recognition that, as a non-Indigenous person myself, a lot of this learning has come through working with faculty, staff, and students in our program. So the 5 pieces I'll touch on. First is ensuring Indigenous data sovereignty and ownership. Second is improving Indigenous representation in the system design and governance. Third is enhancing data disaggregation and tribal-specific identification. Fourth, incorporating Indigenous perspectives on health and well-being. And lastly, improving data accessibility and capacity building. So first, thinking about data sovereignty and ownership, we need to recognize that Indigenous peoples have a right to govern the collection, ownership, and application of their own data. So it's really about them having that power to control what happens with data collection and also the use of that data. Establishing formal data sharing agreements that grant tribes full ownership. So if data is collected of a tribal population, whether it's a federal system, state system, or otherwise, tribes should have that full ownership and control of that data. We also want to be including tribal-led advisory councils to oversee that data policy. And this could be in a variety of different formats. There are some institutional review boards that tribes have set up themselves. Other tribes have council resolutions and more legal framework to go through and grant data access and data policy. So there's a variety of different ways that this can happen, but tribes should be leading those advising and for that data use. And then we also need to make sure that tribes can directly access their data without requiring approval from federal agencies would be a great step in the process, because the data is the tribe's data. From my opinion, it doesn't matter where it's housed or who collects it. If it is of that tribal population, the data is theirs. Next, improving Indigenous representation in system design and governance. We need to include Indigenous researchers, leaders, and community in the planning, collection, and interpretation of the data. And this isn't just identifying people that are out there doing the work already, but also where are ways that we can incorporate new people into the system and into the planning, data collection, et cetera. Hiring Indigenous staff to collect data within their own communities has shown to be very successful in a lot of our programs. I mentioned the tribal PRAMS collection in South Dakota included a lot more community engagement and staff that were of and from those communities. Again, Indigenous advisory boards for data systems. So not just on the data use piece, but also on the planning, the collection, interpretation. So involving Indigenous populations and communities all the way through the whole process. And then making sure those Indigenous people are at the table when it comes to decision making. And I've already touched on this issue a bit, but this is a big issue that comes up in all of our discussions, not just in the classroom, but at conferences and meetings, even in our faculty meetings. We always talk about how can we better be using the data to have tribal specific identification and what that means. So we need to make sure that we're collecting tribal affiliation beyond just general American Indian, Alaska Native categories. Because when we have that, it's then going to allow for appropriate disaggregation of the data. So instead of just looking at one group of American Indian people across a state or across a country, we'd be able to look at different tribal populations and see what the needs are, see what the health issues are. We also need to take approaches to address racial misclassification through improved data collection methods and reporting. And this often takes a cooperation across a range of different fields and offices within a state. The state of North Dakota has recently implemented efforts to improve this, and this has taken a big lift by working with healthcare systems, coroner's office, vital statistics and people at the state, and even more people, just to try to get everyone on board of better identifying individuals and a process in place to make sure that those identifications are accurate. And then we also want to make sure that we are expanding our sampling of American Indian populations and Indigenous populations to make sure that we do have that adequate representation. And that really does speak loudly to urban Indigenous populations as well. In the United States, there is an Urban Indian Health Institute that's based out of Seattle. And so they do work across the country in different urban areas. But again, there's only one center that's sort of leading all of that work. So there's a lot of work that needs to be done in not just the reservation areas in the country, but also among the urban dwelling populations. Next, we want to make sure we're incorporating Indigenous perspectives on health and well-being. So some of those strength-based measures and questions that I've already mentioned and that Dr. Warren will be getting into should be on surveys, should be in interviews. We also want to make sure that we have culturally relevant metrics that we're collecting on. So things like community connections, food sovereignty, language preservations. These are just a few of the pieces. I've also had students talk about Indigenous physical activity. So not just thinking about, oh, they're playing basketball or they're out for a run, but hiking, foraging, collecting food from the local environment. Those are also forms of physical activity, but they're also very specific cultural activities for many tribal populations. We can also use more mixed methods approaches to thinking through qualitative and quantitative data at the same time to help inform a deeper understanding of what we're collecting. And then we can adapt terminology to be culturally appropriate and then include traditional practices as health factors. So not just thinking through traditional practices as an exposure that should predict a health outcome, but participating in tradition may be that health outcome that we want to look at. Then we also want to make sure that we're improving data collection and capacity building among tribes and tribal serving organizations. So data should be accessible to the tribal level rather than just the state or national aggregates. I've already mentioned this several different times. We could also provide more regional data for Indigenous populations, as some of our tribal nations do cross state lines. So in North Dakota, we have the Standing Rock Reservation crosses the North Dakota and South Dakota border. Sisseton, Wahpeton, and Oyate, which is headquartered in South Dakota, does have part of their tribal lands in North Dakota. The Navajo Nation in the Southwest crosses several different state lines as well. So taking a more regional approach to some of those tribes may be the better way to go than just focusing on a state. We also need to invest in education and training for data for community members. So not just keeping it in the ivory tower of academia or large federal government agencies, but taking the data to community members and letting them know what it is and how they can use it. We also need to fund more training for data collection and for staff in Indigenous communities. And I would argue that it's not just on the ground type of training, but also be thinking through how can we train individuals in a more academic setting to best respond to the needs of Indigenous communities. And obviously, it's going to take money to do a lot of these. And especially if we want to get to the point where tribes are able to collect and manage data themselves, thinking through technological upgrades and infrastructure for tribal areas is really important to make sure that if a tribe has data and they want to own the data, that they can store the data themselves and not rely on a third party to, have access to the data in the cloud or have servers off reservation lands. So now that we have an overview of some of these recommendations, some of the pieces that we talk about within our training of our PhD students, I want to turn things over to Anna Kielström, who is going to be talking about her approach to thinking through the Finn Health study and some of the data pieces important to that. So whenever you are ready, and just let me know when you want me to advance the slides.
Thank you. Thank you so much, Dr. Williams, and thank you for letting me be here today. I am Finnish, I'm non-Sámi, and when I speak about the Finn Health study today through a Sámi Indigenous lens, that is only through the studies that I have read, through conversations I've had with community members, and what I have learned independently in my throughout my life. So I do not have lived experiences of the Sámi people, and I take full responsibility for any potential biases or mistakes in what I present here today. Next slide, please, Dr. Williams. So a brief overview of the Finn Health study. So this is a national health surveillance system in Finland, and this was a critique that I wrote for Dr. Williams' applied epidemiology class last year, where we were to critique an existing health surveillance system and how well or not well it takes into consideration Indigenous populations. So I looked at the 2017 Finn Health study by the Finnish Institute for Health and Welfare. And the Finn Health study looks at several aspects of health and well-being of adults over the age of 18 who live in Finland. And some of the health-related events under surveillance in this study are, for instance, functional capacity and well-being, exercise, alcohol consumption, smoking, and access to care. The data collection methods included health examination and surveys, and during the health examinations, they also collected various measurements, which was then followed by health interviews. Over 7,000 people participated in the Finn Health study, and for sampling, they used a multi-stage complex sampling design from the population information system in Finland. The data from the Finn Health study are used to support disease prevention, health promotion, healthcare improvement, and it was conducted in 50 health center districts across Finland, including areas in Sápmi, the land of the Sámi people. And one of the study sites was in Utsjoki, which is a predominantly Sámi populated municipality. Next slide, please. So what about Sámi or Indigenous representation in the Finn Health study? First of all, Finnish population registries do not collect or contain any information about race, ethnicity, or minority status. There are no available data from this study on these variables either. The study did include that predominantly Sámi populated area of Utsjoki, but there are no reliable data available on how many Sámi people participated. The surveys in the study were available in Finnish, Swedish, and English, but not in Sámi languages. Mother tongue was one of the questions in the surveys, which may give some indication of Sámi participation. However, it's a pretty unreliable indicator, as many Sámi people are not fluent Sámi speakers and may list Finnish as their mother tongue due to historical discrimination based on speaking Sámi languages. However, it's worth noting that out of the eligible participants who listed Sámi as their mother tongue, they participated in the study at higher rates than those whose mother tongue was listed as Finnish or Swedish. So the participation rate was 78% among Sámi speaking, or among those who listed Sámi as their mother tongue, and compared to 70% for Finnish speaking individuals and 72% for Swedish speaking individuals. This is important in the sense that there seemed to be a desire to participate in the study among the Sámi speaking population, but the study did not report or indicate what type of community engagement work was potentially done to encourage participation among the Sámi. So that I am not aware of based on the study report. The FinHealth study data may have potential value to Sámi participants. So previous studies from Norway and Sweden suggest that Sámi people have more mental health distress than non-Sámi people, and the mental health indicators in this study may offer some understanding about Sámi well-being in Finland. The survey also asks about experiences in primary care, and these types of questions could help potentially identify some gaps in services for the Sámi people, especially related to Sámi language and culturally relevant services. Also, the socioeconomic factors in the data may help recognize some potential disparities in income and education. And finally, considering that parts of Sápmi are very rural, the data pertaining to ease of access to care may potentially help in advocacy for improved access to care. Next slide, please. So next, a little bit about the strengths and limitations of the FinHealth study. So there are several strengths in this study. First, considering the comprehensive questionnaires and health examination, it does have the potential to inform matters related to health, well-being, and healthcare services in a meaningful way. The health examinations may offer insight into various indicators of health, potentially catching risk factors or concerning trends on a national level so that any new health promoting interventions could be created. These types of data may also help develop Sámi-specific, Sámi-led programs that incorporate Sámi culture, values, traditional diets, and spirituality. Second, the study included several different areas in Finland, and the largest area is in Sápmi and contains the town of Utsjoki, which is primarily Sámi populated. This could give valuable information about Sámi needs in different parts of the country, including urban Sámi people in the bigger cities. Third, each participant in the study received a comprehensive health report at the end of the study, which may be helpful, especially for Sámi people in more remote areas who may not have easy access to regular primary care. And then the weaknesses of the FinHealth study in serving Indigenous populations. There are many weaknesses. First, as discussed prior, the study does not specifically ask about race or ethnicity or minority status. The study does gather data on various health indicators, but it doesn't allow for any analysis on Sámi-specific health and well-being. Second, while the study provides information on whether adult residents of Finland have experienced depression or anxiety or sought out mental health care, it does not ask questions about what promotes mental health. So that strength-based those strengths-based questions that Dr. Williams was talking about. So those types of questions may help understand culture-specific protective factors that could be utilized in program planning. Third, the health examination component of the study definitely strengthened the data, but less people participated in that part of the survey, significantly less compared to the actual survey or the electronic survey. So this may in part be due to difficulty in getting to a healthcare center or taking time off from work, but it's also important to consider that Sámi people may be reluctant to attend health examinations due to the colonialist history in the Nordic countries and unethical medical testing and procedures that were often done without consent. Fourth, although eligible individuals whose native language is Sámi participated at a relatively high rate, the study materials were only provided in Finnish, English, and Swedish. Next slide, please. And the last part of my part of this presentation is about recommendations to better meet the needs of Indigenous populations. So Dr. Williams has already touched on a lot of these, but specific to the FinHealth study, including race, ethnicity, minority status in public health surveillance systems in Finland would be important to accurately estimate Sámi population numbers and to direct appropriate resources to Sámi-led initiatives. But to accomplish this in an ethical and culturally responsive way, Sámi partners and decision makers should be consulted on how best to ask about race and ethnicity and minority status as it relates to Sámi people, because there are significant differences in the Nordic countries in how Sámi status is defined, and also to promote trust in data collection. Data sovereignty needs to be made a priority, but I'll talk a little bit more about that in just a little bit. Then to gather feedback from, it would be important to gather feedback from Sámi community members on the type of health research that's needed. So considering the status of Sámi people as Indigenous people of the European Union with a right for self-determination, it's essential to ensure that the health research that is conducted with Sámi people aligns with Sámi community needs and research priorities. Next, it's important to engage Sámi scholars and community members as research partners. A good rule of thumb would be nothing about Sámi people without Sámi people. So recruiting Sámi nurses, lab technicians, researchers, and research assistants may help promote community trust in the surveillance system and allow for Sámi voices to be included in study design and methodology as well. Data sovereignty, Sámi people should have ownership of all of their own health data. Data sharing agreements can be created as a collaborative effort that's led by Sámi partners, but ultimately it is up to the Sámi communities in Finland to decide how their health data are used. Processes can be created where anyone who's interested in using any public health data related to the Sámi people has to undergo an approval process or educational modules to prevent misuse of data. And then include questions about community strength. So the FinHealth study, as I mentioned, includes multiple questions about mental health, but no questions were noted about mental health promoting protective factors. So including that strengths-based approach aligns with what Indigenous communities have been advocating for a long time, to be seen not just for their weaknesses and community challenges that are often rooted in colonialism, but their immense cultural capital as well. So a strengths-based approach may help in the advocacy work for Sámi-led, culture-based mental health initiatives as well. And then part of this would also be to, a strengths-based approach would be to strengthen Sámi cultures and languages by providing all information sheets, questionnaires, and health examinations in Sámi languages as well. Thank you so much.
Thank you, Anna, for that overview of your work. So next, just to transition a bit to some more of the end product, at least what we think about in academic circles, is thinking through where we're at with some Sámi health research. As I said at the top of the hour, this section is not expected to be a comprehensive overview of what is out there for Sámi health research, but what I was able to find while prepping for this talk and essentially my overview of where we're at with Sámi research, and I've tried to identify pieces specific to Finland as best as I can. So taking a look at what's out there, I went and did a literature search within PubMed, specifically looking at Sámi research in Finland and Sámi research in Lapland. And as you can see, there were about 43 results that showed up in the first search and 8 results in the second search. Overall, looking at the just the abstracts and a few of the articles, we were able to land on roughly 43 papers that showed up. And the different study types that showed up it's important to understand kind of where we're looking at for data and considering some of these studies. So we had 7 literature reviews, and these largely looked at Sámi health in general, traditional medicine, cancer, and suicide prevention. The primary data collection papers, and these are not just in Finland, it's across Nordic countries in the Arctic region largely, but they used interviews, questionnaires, health examinations, genetic analyses, so a variety of different types of data collection. And then for the secondary data analysis papers, this was the use of registry data, population records, and previously collected data sets as well. So some of the standard approaches when we're thinking through that secondary data. When looking at the populations included, 8 of the studies were multi-country specific, and most of these 8 studies included Sweden, Norway, Finland, and Russia populations for the Sámi people. Looking specifically at Finland, 15 of the studies focused on Finnish populations, so Sámi and non-Sámi populations aggregated, and forgot to put the number here, so I don't remember it off the top of my head, but a number of these did talk about both Sámi and non-Sámi populations within the study, but they were grouped together for essentially the main analyses. And then 10 studies did show up that were exclusively focused on Finnish Sámi population. So there is that burgeoning evidence base specifically to this population. Now, when looking at these papers in general, just looking at the 36 papers that were not review papers, there is both qualitative and quantitative approaches. The qualitative studies did consider things like traditional medicine, experiences of urban Sámi regarding health and well-being, different Sámi populations' expectations with nursing home care, COVID-19, ethical considerations for participatory-based research, et cetera. So again, sort of a range of data collection and study within those qualitative papers. And then for the quantitative studies, this is where we obviously see more of the epidemiologic approaches, thinking through cancer incidence and mortality, some demographic work, genetic and biomedical testing, analyses of registry data, historical records. And what I think is also very interesting is thinking through some of those Sámi-specific environmental health impacts, like radiation dose and exposure to contaminants. What I learned prepping for this is due to some industry in the peninsula in Russia that borders Sámi area in Finland. And then looking at the health outcomes, there's quite an expansive list of health outcomes given we saw 36 kind of primary studies looking at cancer, looking at mortality and life expectancy, cardiovascular disease, and mental health. So a good chunk of this is looking at more of those chronic disease conditions that we often do look at in public health. But then we also have things like infectious disease. I think COVID-19 was really the opportunity where some of those papers came out of. And then thinking about things like nutritional status and diet, environmental health, genetic health factors, and kind of general health and well-being. So given we identified these 43 studies, quite a range of different health outcomes that we're looking at here. But then I think this is also a strength of this set of studies that we looked at, or I looked at for this, and really try to identify what were some of the Sámi-specific determinants of health that were looked at. And one of the big ones was looking at diet and traditional activities. So there was a lot of focus on reindeer herding, reindeer as a source of protein, fish, berries, etc. Traditional medicine practices and usages was part of, I think that was more of the Sámi Norse study from Norway, but then also looking at a variety of other types of culturally connected determinants of health, like identity, language, ecologic knowledge, historical experiences of discrimination. So thinking through sort of that Indigenous specific or Sámi specific, deficit-based, but still very important determinant of health. And then also thinking through spirituality and holistic worldviews of perceptions of health and illness. So again, quite a range of different pieces to consider with Sámi-specific determinants of health. And again, this list isn't just from the Finnish studies, but thinking about Sámi populations across Norway, Sweden, Finland, and Russia.
Dr. Williams, just a heads up that you have 5 minutes.
Yes, yep, thank you. So just to do a quick summary of the current research, the strengths of the approach are, there's a really great foundation across the broader region of doing the Sámi work. And there's been really excellent consideration of Sámi determinants of health. We just looked at a range of different determinants of health there. And we have both qualitative and quantitative approaches. And there's been different approaches like survey methods and biomedical sampling. So really a range of data collection approaches among the Sámi people in the region, which is exciting to see. It means that there's a lot of things to build off of. But then there's obviously a lot of opportunities here as well. With the Sámi-specific studies in Finland, less than 25% of the studies identified in Finland were Sámi-specific. So thinking through more opportunities to concentrate on Sámi populations, both urban and living in the north of the country as well. This is a little biased, this next point, because I do perinatal work, but thinking through things like life course approaches, perinatal work, pediatric research is also needed to be thinking about what are the lifelong implications of things like cultural exposures, but also some of the negative side of things like discrimination and colonization pieces as well. From what I looked at, the mixed methods approach appears to be somewhat limited. And this is really important, especially when we're kind of building some of the groundwork for broadening out the research, because we can then dive into more detailed understanding of some of the issues with both that qualitative and that quantitative approach. So, maybe taking some surveys and informing qualitative approaches, or flipping that around as well to dig into some of the issues identified by Sámi community and Sámi populations. We can also have a more reciprocal approach to research, especially considering data dissemination to community. This was informed by conversations I've had with Anna, who's had a lot of conversations with Sámi community members, Sámi Health Board, Sámi Parliament, and thinking through how data should be brought back to the community, shared with community, to help inform some of the work that they're doing. And then there can also be refinement of research focus. So in general, there's relatively few studies, but it seems to be a broad range of health topics. So really developing some of those health topics and getting into some of the more detailed work would be fantastic. So just a brief overview of the last hour. Some of the key issues in Indigenous health monitoring, representation challenges, again, with the sample sizes and the aggregation of diverse groups, may not allow us to identify all those specific health trends. There's some methodological barriers. So in terms of racial misclassification, absence of Indigenous perspectives in the research design, limited access to data, and making sure that cultural aspects are appropriately included into the questionnaires. And then some conceptual differences that Dr. Warren will get into in a future talk as well, thinking through some of those Western indicators that are important clinically versus some Indigenous indicators, and thinking through how we combine variety approaches all in one study. So what to do next? So just quickly for some of my recommendations, and we'll have time for commentary and questions. But first, making sure we respect Indigenous data sovereignty. So thinking through data sharing agreements, Indigenous-led advisory councils, and thinking through Indigenous implementation of Indigenous principles for data. We should also improve our research collaborations across groups. Doing things like this webinar series is a great start of including Sámi Parliament, and a variety of different other agencies as well, but also be thinking about how we can better incorporate Indigenous staff and researchers into our work. And then through data collection, thinking through language in the materials that are used to help drive up participation, make sure we're collecting community-specific identifiers beyond just general health status and general exposures, and having an understanding of strength-based measures. And then lastly, for everyone in this group, most importantly, we would love to see you at our next 2 webinars as well in May and in June. So please come back, get more detail into some of these recommendations and these next steps as well. So I thank you for the opportunity to come and share this work with you. But next I will turn it over to Lydia Hakala, who will be giving us a commentary on this topic. Lydia is a researcher who has long studied the health and well-being of the Sámi community, and how it reflects on the situation of health and well-being research in Finland.
Okay, thank you very much, Dr. Williams. Yes, hello everybody. I'm a retired researcher nowadays in Sámi Wellbeing, Social and Health Services, and Sámi Research Ethics. Well-being in my case is understood in a broad sense, like Indigenous people, including livelihoods, language, culture, community identity, belonging, and so on. So it's a kind of holistic understanding. I thank for the opportunity to comment. However, I'm not sure if I'm not the really right person to do it, since I'm not an expert in epidemiological research, neither in health research for that matter. My background is that of social sciences. I did my PhD in reindeer talk. And because of my work experience, I have studied this social and health services and Sámi well-being in the long run. So I speak from that perspective. I have here 3 major points, like our president always has. I'm talking about some ethical questions involved, and then some research practices, and then some research method questions. It is surprising me to listen the case in US, how similar the situations and problems are with indigenous people around the world. I can recognize many of them. My first comment is maybe more like an existential question. Pondering on the scientific foundation of epidemiological research, I wonder how well the Sámi people can be considered as genetically consistent group. Do we have enough information of it? Are there grounds for epidemiological research or studies, ethnically determined diseases or manifestations or causes of diseases and so on? Or is it rather a question of cultural similarities due to similar livelihoods, nutrition habits, local living conditions, lifestyles, and so on? Population studies in another meaning, maybe. But what are we actually looking for is my big question. Then the second point is there a few principled research ethical questions which have some practical dimensions. As Anna said, in Finland, we do not have ethnically based data collection of the Sámi. The Finnish Institute for Health and Welfare has done some collection of data for immigrant groups and Roma people, but not for the especially Sámi people. There has been negotiation concerning it, but Sámi Parliament would not approve such. And so there is also no ethnic marker in the national population registers. Mother tongue is sometimes used, but it's like Anna said, it's not a comprehensive or representative variable. The information is incomplete because the statistical practice concerning birth announcement has been changed several times over the years. And for 20 years period, it was not possible to register Sámi as your or your child's mother tongue without additional measures of which people were not informed. As a result, today, many Sámi don't know which is their registered mother tongue, or they don't bother to change it for many reasons. Because Sámi are usually multilingual, for many it is difficult to decide which is the mother tongue. You can only mark one mother tongue there. People cannot have 2 or 3 like they have in practice. And also many cannot write Sámi language because it was not taught at schools. So which is the predominant language depends on your living surroundings to what language you can use in everyday life. There are many questions to it, and it dates back to the overall loss of language due to severe assimilation acts by the school institution and mainstream society's monolingual policies. We can at least talk of neglect of maintaining Sámi language, if not explicit decision to discriminate, like in Norway. So the register contains several inconsistencies due to areal and generational outcomes of assimilation and the reaction of the Sámis. The only comprehensive information of the Sámi people in Finland is the electoral role of the Sámi Parliament. it is owned by the Sámi Parliament and managed together with the National Population Registry Office. It's updated in every 4 years when the elections are coming. It is not an open register. It is legally meant for conducting the elections of the Sámi Parliament. So as I see, collecting ethnic data of Sámi population would require profound changes concerning ownership and decision-making rights, like has been said today in this webinar several times. They are the crucial issues which have to be taken into consideration regarding Sámi. I can see that fundamental data protection arrangements are needed together with the facilities, competencies, and resources to handle these changes in practice. But the ultimate decision is under the self-determination of Sámi Parliament and depends on their conclusions, considerations. We cannot force them or so. And so in this respect, the relationships must be based on mutual trust and respect between those institutes which are collecting the ethnically based data and the Sámi Parliament. Somehow I feel that that this calls for deep paradigm changes, that there are many changes needed also in the operating methods, perhaps even in the legislation, to solve the contradictions in a viable and decent manner. You probably know that in the Nordic countries, the National Institutes of Health, compared to many European countries, have exceptionally strong and extensive authority over collection, registration, and analysis of data over individuals and population groups. In the name of public interest, people don't have individual rights to their information, regardless which population group they belong. And ultimately, it should be recognized and noted that Sámi are not an ethnic group and neither a language minority, how they are often called in Finland. They are people with indigenous rights, and this should be the recognized starting point. And then we should implement the constitutional right of the Sámi as indigenous people into lower legislation, what it means in relation to control and decide and use decide how to use the ownership and how to use, who has the right to use the data. So they are very fundamental sort of missing facilities what we have, or which are ahead of us, I think, before we can move. And then finally, a few words of the method, of the content and methods of the service. As I have understood, the hegemonic understanding of epidemiology and population research requires big data, extensive samples based on, and the studies are based on analysis of averages and aims at generalizations. Regarding my experience in some Sámi well-being research, what we rather need is focus on small evidences, ability to discover and focus the details, the signs and the hints and the divergences of differences in the material. not looking for the great generalizations, but the minor signs. Maybe what Andrew Williams had this in his slide about aggregation masks tribal evidence is somehow connected with it, that with certain measures using either mixed methods like we have used both quantitative and qualitative, we get a better understanding of the phenomena and better cultural understanding of how to use quantitative methods. And in our well-being study, we also developed a multidimensional correspondence analysis method regarding the question of connectedness to Sámi culture, which is one of the dimensions of Sámi well-being. And we got very new results and insights. We maybe not yet proved facts, but sort of good beginnings for a better theoretical understanding, which somehow is the thing which is needed, that we need also a better base for those surveys of Sámi health and well-being, which is based on the theoretical understanding of the indigenous people and knowledge. And it needs to be developed as the foundation of those surveys. It was apparent also from Andrew's presentation that certain aspects are difficult to ask in the survey format, even in a culturally adapted survey format. So things are often not univariate. Therefore, the combined effects many variables need to be investigated. We find seldom direct relationships between two variables, at least that would be statistically significant. We need to be able to close read the data in order to get to the track and make new findings. Yes, the population survey format and the analysis methods need to be developed, I would say. That's another challenge besides the ownership or the sovereignty questions. But in final conclusion, I could say that culturally relevant research may also be scientifically relevant, that we have to strive towards that in our work to improve the methodological or theoretical background. Thank you.
Thank you so much to all our speakers. Thank you, Dr. Andrew Williams and Anna Kihlström and Dr. Donald Warren and Dr. Lydia Heikkilä. If you do have some questions or comments, you can put them in the Q&A box and we'll be able to see them from there. Lydia lost her connection. I'll add her back in. Donald, I know you put your camera on just now. Would you like to say a couple of thoughts at this point?
Just really appreciated the entire presentation and also Dr. Heikkilä's comments, and recognizing that there's not going to be likely huge genetic differences across the populations, but that's true across all races. And it's about 99.9% of DNA is shared across what we call the racial groups. So much of this is related to the social constructs and the historical dynamics that lead to health disparities and inequities. So in Lakota, we say mitakuye oyasi, which means we are all related. And it's very true from a genetic perspective that we're so closely connected. But it's those social constructs over history and the colonization of original inhabitants of various parts of the earth that lead to health inequities, and that's really, I think, is a starting point important to think about. And I'm really looking forward to the next 2 webinars, and just very honored to be here. So just wanted to say that. Thank you so much.
Thank you. And if you can take a moment to scan the code again and give us some feedback on today's session, we'll be able to take that into consideration with the upcoming webinars. I think there was a total about 60 people online. I know there was a couple of participants who joined in with a group, so maybe the number is more. So, and then in the initial questions that Neela had asked, a couple of people managed to respond to that. And we had a majority of researchers, otherwise some other of the smaller groups, and I would say that most people did not have a prior experience in Indigenous health and well-being research, but were very interested in the topic. So that is a small snippet of who was listening to the talk today. And then I see in the Q&A there's been sharing of the ethical guidelines that have been published recently by the Sámi Parliament and the Center of Sámi Health Research. I believe we've shared these with you, Dr. Andrew and Dr. Donald, but for everybody else listening, that's a really good point to start looking at the ethical considerations in the Sámi concept. And then maybe there's something on the chat side as well. Oh yeah, that was Mari sent the link. But Dr. Andrew, would you like to say something at this point?
Yeah, I just want to, again, thanks to everyone for the opportunity. And I really do appreciate the commentary by Dr. Heikkilä. A lot of her comments are well taken, and I totally agree with some of the somewhat criticisms of epidemiology, because we're not necessarily looking at wanting to look at a very large population, but really want to make sure that the research is very specific and relevant to the Sámi people. So thinking through some of those issues of disaggregation and making sure the sample that we're collecting data from is appropriate is what we want to get to. And also, in kind of streaming throughout her commentary, I very much agree that this is not going to be a quick fix. There's lots of policy issues at the Finnish governmental side, THL side, and the Sámi Parliament side, Sámi Health Board. But getting started on the work is the main thing, and making sure that all the relevant people are on board and moving forward together in the right situation. And hopefully this can just be a start for some of that process. But we know and expect that this is not an easy task to address some of these concerns that are hundreds of years old in many situations. But really looking forward to the next phase of the webinar and continued conversation on this topic. So it's very important to consider these issues. So thank you very much.
Thank you. And we at THL are very grateful for our cooperation agreement with the Sámi Parliament. And this webinar has been kind of part of that agreement in order for us to better understand all the issues related to Indigenous health and well-being studies, as well as give more education and capacity building to our staff at THL. So thank you for joining us on this collaboration as well. The rest of the team, also thank you to Neela Rahko, who was not able to be here on video today as he's in Tromsø, but was listening with another team of project members there. And thank you also to the other members that have been part of preparing these seminars and webinars. So Wupila Tanka, thank you, Gito, Tak, and Spaseb. Thank you, everyone, and hope to see you at the next webinar.
Thank you.
Thank you, everyone.
Kiitos.